point of view.
So where does that area of weakness correspond to? Yeah, it might be the left arm, huh? Would that be a upper motor neuron or a lower motor neuron lesion?
Upper.
Yeah, it would be upper. Okay. Now, one thing we like to do when we evaluate patients is when they present with motor weakness, we like to differentiate upper versus lower motor neuron lesions. And they present differently. Both can cause motor weakness. Okay? But in terms of the weakness or the paralysis, if the lesion is upper motor neuron, it tends to be a spastic paralysis, where with time, muscle tone increases. Okay? Whereas with a lower motor neuron lesion, flaccid paralysis, where there's a loss of muscle tone. The muscle becomes flaccid. In terms of deep tendon reflexes, of the involved muscles, if it's upper motor neuron, reflexes in the area of paralysis are going to be hyperactive. Whereas with lower motor neuron lesions, hypoactive. Now,
What is DTR?
what's that?
What does that mean, DTR?
Well, deep tendon reflexes.
Oh.
You know how they do a knee-jerk reflex and Achilles reflex?
So is that when they do like, oh, I just really hit my, yeah, I know you heard
That
that.
has nothing to do with what you just did.
No, like the hyperactive. I was trying to
We're
get an
gonna
image.
demonstrate the reflexes
Okay,
just
I
a
hit
little
myself
bit.
really hard.
Yeah,
just now.
that's dangerous.
I really didn't mean
Are
to.
you okay?
Yeah, I'm great.
Now, if the damage is to nerves that innervate lower extremities, we also assess a Babinski reflex. With upper motor neuron damage, the Babinski is abnormal. Lower motor neuron, normal Babinski. Of course, tone, and this goes along with paralysis, tone is
Bless you.
increased with upper motor neuron lesion, decreased with lower motor neuron. In fact, oftentimes with upper motor neuron lesions, you get something called clasp knife spasticity, meaning that, okay, you might have an extremity that exhibits spastic
Bless
paralysis.
you.
If you go to extend the extremity, there's increased tone, and then suddenly lets go. Okay, it's like opening a switchblade. You know, you meet increased resistance, and then suddenly it pops open. So that's called clasp knife spasticity. You often see that with upper motor neuron lesions, whereas with lower motor neuron lesions, there's no tone. And there's some other minor differences like fasciculations. This is like several muscle fibers just twitching involuntarily. You can see that sometimes with lower motor neuron lesions, but you don't see it with upper motor neuron. So the idea is that when someone presents with motor weakness, we can use the physical findings to differentiate upper versus lower motor neuron. Okay. And sometimes that tells us, okay, we want to do an MRI of the brain as opposed to an MRI of the lumbar spine.
Dr. Pinner, would it make sense that if a person had a massive stroke in the left hemisphere of the brain, that they would experience, so if they experience paralysis on the full right side of their body, their legs would be flaccid and their arms would be spastic?
No,
Okay, I'm just thinking of it.
no, that wouldn't make sense.
Okay.
Dr. Penner, you want to hear something cool? Side note. I was watching Grey's Anatomy on Thursday, and they have like this lab for the interns or whatever, and they were dissecting a human brain. So it was cool because it's like we dissected a sheep brain, and then I got to see that. Yeah, but they were human. Yeah, definitely.
Yeah.
Anyway, I just thought it was ironic.
You know how we dissect dogs?
Yes.
At one time, I got this saw, and we opened up the skull cap. But it turns out that it's such a messy procedure that the bang was not worth the buck.
That's what my friend said, that she dissected something and they tried to get, what was it? I don't remember what it was, but they tried to dissect something, and by the time that they got to the brain, it was like mush. It was my friend Hannah.
It kind of gets a little bit mushy.
Yeah.
So oftentimes, for the human brain, what they try to do is when the body is first dies, they try to preserve the brain as soon as possible. Okay. When you're looking at the physical examination on a medical record, oftentimes you'll see a little figure that looks like this. Has anyone seen something like that?
Let's take a picture.
Just today.
Yes.
Yeah, it's a little stiff figure, and it's used to demonstrate the deep tendon reflexes and the Babinski's. And reflexes are often graded 0 to 4 plus, with average being about 2 plus. Now, the most important thing is not that every reflex is 2 plus, but rather symmetry. So, let's say the reflexes, the brachioradialis reflexes, are 1 plus. These are the biceps reflexes on the inside of the elbow. On the outside, these refer to the triceps reflexes. Let's say that the knee jerks are a little bit hyperactive, but it can still be normal as long as they're symmetrical. And these are the Achilles reflexes. And then these arrows down here represent the Babinski findings, Babinski reflexes, and downgoing is normal, at least for anyone who's above 1 year of age.
I hope so.
Okay. And abnormal, and we'll talk about an abnormal Babinski, but you'll see something like this, and if you look at this stick figure, what you immediately see is there's symmetry. That there's no marked abnormality in terms of the deep tendon reflexes. Now, if you were to see something instead that looks like this, that would be abnormal. There would be significant asymmetry. There would be absent reflexes in the left upper extremity.
You said it's 0 to 4?
0 to 4, right.
Okay.
But in this case, there's no reflexes. This is areflexia.
So their limb was just kind of hanging there?
Well, it might well be. Okay. So the idea is you're looking for symmetry. Who wants to volunteer? Who has good reflexes?
No, I don't know.
I don't
I
know.
need someone with good reflexes.
I can catch well. I don't know if that's...
Hunter, all right, Hunter, why don't you just hang out right here.
Can I record you?
No.
I'm doing it anyway.
I'm in it too, you didn't ask me.
I don't.
That's
we
what-
don't
Oh,
use
I
these
thought you
reflex
did.
sounds,
Oh
even
no,
though
it's
they're
not
broken.
you. I recorded one here.
So we may not get an optimal result here. Can you take off your jacket?
Let's go hunting. Yeah, I know this. I was gonna say it, but I didn't know if you would take it the wrong way. So I did it.
Now, one of the key things with doing reflexes is to make sure that the patient is fully relaxed. Why? Because if they have increased tone in their extremities, they're not going to respond appropriately. So what we're going to do is, what I like to do is, for instance, if we do a biceps reflex, I like to put my thumb on the biceps tendon right here, and I'll tap my thumb over the tendon. That's going to still cause a displacement of the biceps tendon that should elicit the reflex. So I want you to relax as much as you can. Sometimes you'll try to divert their attention by saying, okay, look up at the ceiling. Now, I can feel a little movement in her biceps, but it's not very noticeable. I'd really like to use this end, but this thing's not working. See if I can. Can you see anything?
Yeah, like it pulls back.
Can you see that?
Yeah, I see it.
So she's got a little bit, I would call this probably 1+. Look up.
That's like a two.
Okay. No, it's really 1+. Yeah, it's not that it's that marked.
Sarah sees an abnormality.
Now, for the triceps, you have to have the person kind of relax the arm. So right now, she's not relaxed enough. Okay? Let it fall. Okay. I'm going to hit her triceps tendon. Let it fall. Look up at the ceiling. See how she's not really letting it fall? Okay. So we're going to try it, although she's not cooperating much. All right, let it fall.
Let it go with your lead.
I'm trying to be loose.
Did you see that?
Yes.
Okay, that was a better reflex here in the triceps. Let's see if it's symmetrical. Let it fall.
No.
Don't say anything, just let her relax and look up at the ceiling. Let it fall. All right. All that, just let it. Okay, so really that's kind of 1 to 2+ as well. Now, if you did brachioradialis, we're going to tap right around here. And that's more like 2+ for that reflex.
How do
Okay.
you determine whether it's, I mean, just because I'm curious, 1+, 2+?
0 is absent. 1+ is a minimal response that either I can only feel or if I can see it, it's fairly mild. 2+, I get a 2+, if you see a bunch of them, you know what 2+ is. With 4+, there's clonus. In other words, there's continued contraction. Okay, 3+ is just a hyperactive reflex without clonus. So that's pretty prominent. Now that's 2+ right there. That's 3+. All right,
Sarah,
so
do you
it's
see
about
any
3+
abnormalities?
bilaterally. That's normal. Now go ahead and kneel up on this table. These are the Achilles. Now, that's about 2+. Now I'm going to have you take off your shoes.
Oh, no, not again.
If you're wearing socks.
Twice today.
Some people enjoy this.
Oh, you did this in the morning?
I don't know if my feet.
Same.
Extra points.
All
We're doing the voluntary
right, put them on there. I'll give you extra.
Okay.
Now, the key thing is to make sure the patient's not withdrawing. Okay. What you is going to take an object and move it from the lateral aspect of the foot toward the big toe. Okay, try to relax. Try to look up at the ceiling. Watch your big toe closely. That's the key. Okay, did you see how it turned down at the end? She was withdrawing at first, and then she responded. All right, let's try this one here. Okay, try not to pull back. Did you see how it goes down? All right, that's a normal response for the toes to go down. If the big toe goes up and the other ones flare, that's an abnormal Babinski. So her reflexes are fairly symmetrical, and she's got down-going or normal Babinskis. That's what we expect. Okay? Now, let's look at this. Thank you. I'll give you extra, because you've done this twice today.
Yeah.
I feel like when they're trying to, like the first responders are trying to assess,
Well, if they do a neurologic exam, that's part of it, yes.
right.
Okay.
Dr. Printer, my dad was on call when the shooter was at the airport. He had to work on them.
Really?
Mhm.
Wow.
A woman got trampled by people and no one helped her to stand up
Okay, well, that's
when they were running out the hospital. Yeah, I was really upset with humanity when he told me that. Because that was the first person they worked on, and they had to go deal with the shooter when they actually figured out what
You
was
know what was
happening.
crazy? When I decided to leave ULL, they had a bombing at the like some
Ooh,
kind of bomb threat. Not
really?
bombing, bomb threat.
Well, you know, I thought earlier today,
Scandalous.
Jordan tried
What-
to jump off that table. I thought we were going to suicide attempt.
That was Sarah's idea. She instilled it in my
All
head.
right. Now, I'm going to go through the muscles and nerves that are involved in these reflexes. So just bear with me here. The knee jerk reflex, it's also called the quadriceps reflex. because it's the quadriceps contraction that brings it about. The nerve that innervates the quadriceps is the femoral nerve, and the femoral nerve is carrying axons from L2, 3, and 4. Okay? Now, for this Achilles reflex, the muscle that's involved is the gastrocnemius.
So is that why muscles are normally taught before the nervous system? Because like, so you get the muscles and then you get what nerves are?
Yeah, but
Okay.
you could go either way, because either way there's going to be some problems.
Okay.
Just bear with me. Gastrocnemius is innervated by a branch of the sciatic that's carrying S1 axon. Okay? Now, the biceps reflex is mediated by the biceps brachii muscle. That in turn is innervated by the musculocutaneous nerve that's carrying axons from C5 and C6. Okay? And then finally, the other one here is the triceps reflex. It's mediated by the radial nerve carrying axons from C7 and C8. Okay. So how do you remember all these nerves and what axons they carry? Well, you have to be able to count. Okay? You say 1, 2, 3, 4, 5, 6, 7, 8. 1, 2, 3, 4, 5, 6, 7, 8. If you can remember that simple mnemonic.
What's music on?
Okay? So the gastrocnemius reflex, the ankle jerk reflex, mediated by sciatic, carrying fibers from S1. Femoral nerve that innervates the quadriceps, L2, 3, and 4. Musculocutaneous, I went through this earlier, carrying fibers from C5 to C6. Radial nerve innervating the triceps, carrying fibers